Parks located. Alice Gentle, I manage the primary community care team in Health and Social Policy branch of the Ministry. So I'd like to start by acknowledging traditional custodians, the lands each of us are meeting on today, and pay my respects to elders past and present. I'm joining today from the lands of the Wongal people. I'd also like to welcome any Aboriginal and Torres Strait Islander people joining today. Welcome to today's special NGO Communities of Practice meeting. We've extended the invitation today to other interested NGO stakeholders, NGO staff and grant managers across New South Wales Health. To make the session run smoothly, we've asked everyone to mute and turn the cameras off unless you're a presenter. I'd like to welcome my co-chairs for today, Robert Sterling and Joanna Quilty. Rob is clinical lead for the NGO Community of Practice and CEO of NADA, the network of alcohol and other drugs agencies. And Joanna is the CEO of NGOs, the New South Wales Council of Social Services. I want to say thanks to Jo and Rob for their leadership and advocacy in responding to COVID-19 under what have been really challenging circumstances across the NGO sector. We'll also be welcoming today Dr Jan Fizzell, who'll be joining us soon to answer your questions in the Q&A session. Jan's a senior medical advisor in the Office of the Chief Health Officer and a public health expert. And over the last 18 months, she's been one of the public faces of New South Wales COVID-19 response. That Q&A is going to be the main item of today's meeting, and we'll share strategies, local solutions and issues relating to the pandemic response for the NGO sector. We are facing incredibly challenging times, and I know each of you and your organisations have done an enormous amount of work for the COVID-19 response to provide service, leadership, representation and assurance to communities and the vulnerable groups you work with. And you've been tremendous partners with New South Wales Health to manage the impact of COVID-19 across New South Wales. So on behalf of the Ministry, I want to say thank you. And during what's an especially busy period for everyone, we really appreciate your time today. I'm now going to hand over to Rob, who'll provide an update from the last Clinical Council meeting. Thanks, Rob.
Thank you very much, Alice. I'd also like to welcome everyone and also to acknowledge the traditional owners of the land that we're all meeting on today. For me, it's the Gadigal people of the Eora Nation, and I pay my respects to elders past, present and emerging, and acknowledge any Aboriginal and Torres Strait Islander people that are joining us today. I'd also like to acknowledge the work of the non-government sector in supporting people in the community. As we know, your roles have expanded from your core functions to include supporting people during a pandemic, from infection control, vaccination, as well as coping with stress that the pandemic is having on the community. So thank you. We are grateful for all that you do. So the New South Wales COVID-19 Clinical Council provides a peak governance body for clinician engagement to provide expert advice and guidance to the system and to escalate matters that require a statewide or system response. The council is chaired by Deputy Secretary Dr Nigel Lyons from the New South Wales Ministry of Health, and the council is made up of NGO health staff as well as co-chairs of each of the communities of practice. So in my role as co-chair of the NGO Community of Practice, or COP, I attend those meetings and provide updates back to the COP. Whilst much of the discussion is very much focused on the public health system, recently there's been two important items that have been discussed relevant to participants today. So the first one is an overview of the vulnerable population strategy for the COVID-19 vaccination program. And vulnerable populations include aged care, people with a disability, Aboriginal and Torres Strait Islander people, people experiencing homelessness or at risk of homelessness, people with chronic and complex health conditions, including mental health and alcohol and other drugs, pregnant women, and the culturally and linguistically diverse community or COLD community. So the Ministry plans to distribute a vulnerable populations package soon, which will include a strategic framework document, LHD specific demographic overviews, and packages for each vulnerable population group to assist districts in planning the vaccination rollout for all vulnerable people. It takes a tiered approach from routine access to vaccination through to developing bespoke vaccine access models. And I'm sure Dr Fizzell will be drawing on that strategy in her responses today. We know that there's some great examples taking place already. I know the Kirkton Road Centre in South East Sydney Local Health District has been vaccinating people experiencing homelessness in Woolloomooloo. And in Southwest Sydney, going into a residential rehabilitation service to vaccinate NGO staff and people accessing that service. And we really hope that we'll see more of these models take vaccination to where vulnerable people are. The second area is healthcare worker exposure risk matrix and other workforce related documents. So the risk matrix has been released and public health units are using that matrix and finding it helpful. So it can be applied to other settings, and it's available on the New South Wales Health website now, and that link is on the page there. In addition, there's been another document, COVID-19 Workforce Advice for New South Wales Health, that covers matters like leave for positive cases or close contacts in the health workforce. Again, this advice is not for NGOs. However, I get lots of inquiries from NADA members seeking advice, as I'm sure do other peaks. So the document provides useful advice that could be incorporated into NGOs' own internal policies. However, I'd also encourage you to look at the Fair Work website and also to contact Justice Connect, not-for-profit law, if you're wanting specific industrial or legal advice to support you. So I think that brings us nicely into the context for today's webinar. We felt that it was important to open up today's NGO COP to all NGO service providers and their contract managers to have a Q&A of common questions that are coming through to the ministry, to peaks like NADA and NCOS. We know that services have questions about the vaccination of their staff and people they provide services to. We know that there are issues around vaccine hesitancy for both of these groups. And we also know that there's anxiety from service providers about how to respond in the instance of a COVID case or close contact for both of these groups in your services. And we hope that Dr Fizzell will be able to answer many of these questions for you. And with that, I'd like to hand over to Joanna Quilty now, who's going to facilitate our Q&A with Dr Fizzell, and hopefully Dr Fizzell will be joining us. Oh yes, I can see Dr Fizzell there. So we'll now hand over to Joanna.
Thank you very much, Rob. It's great to have so many people participating in this session today. I'd also like to acknowledge that I'm on Gadigal land of the Eora Nation and pay respects to elders past and present. And firstly, thank you so much to you, Dr Fizzell, for finding time to join us in this important session today. We know how incredibly busy you must be, so we really appreciate that you've been able to fit us into your very busy schedule. But we did think, given the current rapidly evolving circumstances that we find ourselves in, and the significant challenges that these are creating for communities right across New South Wales, that it was important to bring together the health and community services NGO sector and to provide the opportunity to ask a range of questions concerning vaccinations, both for employees, but also for the vulnerable clients that we support. Staff across the sector generally fit the definition of authorised worker under the public health orders, and the vulnerable clients that the sector supports can face increased risk when it comes to COVID, but also significant challenges and barriers when it comes to accessing the vaccine. So there are a great many issues that the sector is grappling with at the moment in relation to vaccines. And certainly the new restrictions and requirements that were introduced over the weekend, particularly for the 12 LGAs of concern, have created a range of challenges, a range of new challenges for our sector. So NCOS has written to Minister Hazzard outlining what some of these challenges are and some possible mechanisms for overcoming them. One being that the requirement for staff to have their first vaccination by the 30th of August, for that to be pushed back by at least a week. We've also been talking to DCJ, as have other peaks, regarding the new requirements around rapid antigen testing, which have opened up a whole new world of complexity. And DCJ has today clarified with us that they recognise that for a number of reasons, rapid antigen testing is not going to be practical or indeed possible for DCJ-funded organisations to put in place or to be able to access by the 30th of August, which, let's face it, is only Monday. And that really the priority is for staff to have had their first dose vaccination by the 30th of August, as per the new public health order, but noting that we have written to Minister Hazzard and suggested that that should be pushed back. DCJ has also clarified that where it's not possible to have that first vaccination by the date, whatever that date is going to be, and therefore authorised workers are unvaccinated, then the fallback position should be for regular COVID testing to be undertaken. Now, how frequently that needs to occur, whether staff have to isolate until results are provided, that is information, that they're issues that are being worked through, and further information will be provided. But I know that this clarification will be very much welcomed by many services out there who were really tearing their hair out, trying to work out how on earth were they going to either undertake this new requirement or access it. So there may be some questions, Dr. Fizzell, in relation to that, or, you know, an opportunity for you to provide your view, but I thought useful to throw into the mix what the latest update from DCJ is. So yeah, and certainly there's a raft of other questions that related to the world as we knew it last week, but which still remain relevant today. So I do know that we've got a lot of questions and that we have limited time. Those that can't be answered, hopefully we can identify which of those are the priority, and you can get back to us. But we might get straight into it if that's okay with you, given that we do have a fair few to get through and we want to make the most of your time. So we've divided them around themes, and the first theme relates to public health messaging. You might be aware that NCOS undertook some research into CALD communities' perceptions and attitudes towards vaccination. And that indicated that there are a range of factors contributing to vaccine hesitancy and misinformation. One of them being that people actually get most of their information from social media rather than from government sources. And another factor being that the confusing and rapidly changing public health messaging hasn't helped. So the question is, what strategies are being deployed by New South Wales Health to overcome these issues, and are you getting the right results?
So first of all, thank you everyone for giving me the opportunity today. It's a real pleasure to be here. I think to go with that first question, how are we helping people whose language is not English as a first language from our culturally and linguistically diverse communities access vaccination, and to understand why things are good to be, why it's good to be vaccinated, to do some of our work around explaining why the messaging has changed around the vaccine has been a super important thing. I think as the pandemic, this wave unfolded, the Chief Executive of Multicultural New South Wales and myself were like this. I think we had something like 300 community forums which reached several thousand people from many, many different groups. At the same time, new to this wave of the pandemic, SBS is now simultaneously broadcasting the 11 a.m. press conference, which I know so many of us watch to see what's in for us today, into many, many community languages. We're also working with community organisations with particular grants going out through Multicultural New South Wales to support those people who are community leaders who are providing education to their communities. There's also a daily update from our Multicultural Health Service with key talking points for the day to tell people what the news is in many, many languages. So not just in English, but here are the key messages from New South Wales Health today if you'd like to share them. And we've even gone to doing things like we're now on TikTok, which might sound strange, but many people who are young from linguistically diverse communities are quite fluent in English, and so they're accessing information through TikTok. So we've now got to a 20-second press conference, all the things you need to know in 20 seconds if you don't want to watch the 45-minute one. Also, I think it really is, though, the lived experience. We've got so many community leaders who are posting on social media, who have information on their LinkedIn profiles, who are talking at their church services, who are speaking at community meetings to talk about the importance of immunisation, to try and lay to rest some of the misinformation and try to explain to people why the advice has changed. I think it's a difficult thing for all of us to understand. But the key thing that we've got is what we're doing at the moment is unprecedented in human history. Never before have so many people been vaccinated with the same vaccines at the same time, with such connectedness within the health community, so that we can simultaneously share experiences with these vaccines around the world. And so what would possibly have been a very rare side effect that might have given us 10 years to detect and report on and explain to people, we found in a matter of weeks. Now, that was probably incredibly challenging to us as a public health profession because we've never come across that before. And so trying to clearly communicate the risk of a very, very rare side effect in the context of a disease that at that point was non-existent in Australia, probably we didn't do as well as we should have. We're now in a place though where we do have COVID in our community. We have COVID, I'm currently sitting in Dubbo, we have it in our most vulnerable communities. The Delta strain of COVID is like a heat-seeking missile to disadvantage. It gets to our most vulnerable communities, and all the things that have left our communities most vulnerable during non-COVID times are playing out during COVID times. The desperate need to work, the desperate need to have housing, but unfortunately housing is often very crowded. The thing that is often our strength, which is our extended family and our family networks, is our undoing with COVID, and particularly the Delta strain. And I think that's the hardest thing for all of us to come to terms with. We've got so used to feeling safe, you know, with our mask and our 1.5 meters, and we have, you know, conquered COVID over and over again in New South Wales. And I think this radical mental shift from being able to say, I've got my 1.5 meters, I've got my mask on, and I'm not going out very much, to having to significantly limit our interactions face to face with the people we care about most, and the people we trust most, and the people who are usually in our general life least likely to do us harm, and having to go and say, actually, you're the person most likely to bring COVID into my home, into my household, and into my family, is just such a burden for us all, I think. And I think it's important that we acknowledge that.
So, Dr Fizzell, you mentioned that you're now, not you personally, but that New South Wales Health is on TikTok to get the message out. And, you know, that's fantastic because we know that young people don't necessarily get their information from politicians. They may not necessarily even listen to community leaders. So I think using the platforms that they access is absolutely vital. Is the data indicating that young people are overcoming their vaccine hesitancy and that they are coming forward, that that mechanism or that way of reaching out to them is working?
Yes, and I think one only has to see the queues of people lining up, and the fact that as soon as a tranche of appointments is open, they're pretty much taken up nearly immediately. So at the moment, the demand is outstripping supply. And so we're having this massive effort to mobilise people, to vaccinate people. And I think the thing that we're doing now is we're trying to run two different strategies simultaneously. For the people who are highly motivated and who have the means to be able to travel and have the means to be able to take an afternoon out of their day to get vaccinated, we've got our mass vaccination hubs, and that's where people are going to. But we're also trying to make sure that we reach out to those people who don't have 4 hours in their day where they can go and get vaccinated, so that it's closer to local communities where the centres are a walk-up centre, so you don't have to have navigated a particularly challenging, shall we say, vaccine booking system, and where more and more GPs, pharmacies, as well as New South Wales Health hubs are happening, but also in our very remote areas. We've now got, particularly in the northwest of New South Wales, we now have the Army on the ground helping us vaccinate people in our remote communities. And so I think it's been a struggle for all of us, shall we say, because I think until recently the demand for Pfizer has outstripped supply. But we now know that whether you have the AstraZeneca vaccine or the Pfizer vaccine, you get about 90% protection against hospitalisation for the Delta strain of the virus. So it doesn't matter which of those two vaccines, you're going to get very good protection. And again, whilst there's a rare side effect with the AstraZeneca, the Pfizer has its rare side effects too. So I think the key thing is the best vaccine to get is the one that you can access first. So do not wait for something that you think might be special or clever or different into the future. Delta is here. Delta is hitting us hard. And it's very hard for us as a person, you know, people who need to go to the shops, people who need to go to work, people who are looking after vulnerable communities. The best thing we can do is when we see that opportunity, grab it with both hands.
So in reference to those vulnerable communities, obviously having a population-wide vaccination target at which point we can start opening up is a great thing to have. But it can mask that different groups face higher risks and can also experience lower rates of vaccination for a whole range of reasons. So will New South Wales Health consider setting targets for priority populations and high-risk LGAs to ensure that those really vulnerable groups aren't hidden behind a population-wide target and therefore face greater risks and not be getting the vaccination that they need to?
Yeah, so we certainly are making sure. You will have seen that a lot of our effort around vaccination has gone into southwestern Sydney and Western Sydney, where the risks have been greatest to our vulnerable population. And I think what we've seen in the initial uptake in the first 3 months of the vaccination are people who have the time and have the skills to sit down with a computer and to get those vaccine appointments. Where we are now is we really need to make sure that people who have not had that advantage of having several hours in their life and all, you know, who don't even have a device that's got, you know, credit on it to make those types of appointments are able to access those vaccines readily. And so it is certainly, we certainly have LGA targets. We're certainly looking at our cold populations. We're certainly looking at different groups. But one of the issues with all of our data collection, for example, is that a person may be part of 4 or 5 different priority groups, depending on who they are. So if we looked at me, for example, I have a medical condition, I'm a healthcare worker, I'm a carer for an elderly person, and you know, so that's 3 different ways I could be categorized as being vaccinated, and I'm just one person. So whichever way you looked at me, probably because I got vaccinated through my status as a healthcare worker, I'll get recorded as a healthcare worker, but I won't be picked up as a medically vulnerable person, and I won't be picked up, I'm sure there's another reason I could have been vaccinated early. And I think that's one of the things that we still do need to encourage people who are medically vulnerable, who have got disability, that they are still there as a priority group, and they still do need, when they see those appointments open, we still need to make sure that they can access them. And I know a lot of our local health districts, for example, are trying to do things like at Blacktown Hospital, for example, they've got special clinic times for people who have trouble with noisy or busy environments. So they have more of a calm, quiet clinic area, so that people who do find that sort of overstimulating environment that a fast-paced medical vaccination clinic could, you know, really rock, do have access. And by having it in Blacktown, again, people who have a disability in one of the most vulnerable areas of Sydney have actually got one of the best services. So I'm really hopeful that we'll see those sorts of models roll out more. Well, we've seen Pacific Island healthcare workers working with a walkout clinic in one of our southwestern Sydney nodes. We've had a clinic going in partnership with the Lakemba Muslim Association in one of the hardest hit areas of Canterbury, Bankstown. So we're certainly trying to work with community to make those clinics happen, and to make sure that people are aware that it can be as easy as, you know, walking across the road and down to the community hall, as often as we can make it easy.
So are there any groups that you're particularly worried about that seem to be getting left behind, or indeed any locations where there's a sense that the numbers are rising rapidly and there just isn't the vaccination happening that should be?
Look, I'd be particularly concerned for our regional and rural friends, and that's mostly because access to vaccine has been very, very limited up to until now, that they haven't had something like a Sydney Olympic Park hub that they could easily get to. However, those regional and rural services are being stood up. We have more and more services coming online every single week. And so just because there was nothing a fortnight ago does not mean that there will be nothing in a fortnight's time. And I think for a lot of our regional and rural friends, it has been a very difficult time, because they've gone from a time of having no cases whatsoever to actually being at very high risk and highly vulnerable. So getting past that early complacency where it's not going to come here, and seeing where I am in Dubbo with what happens when it does come, for example, I'd very, very much really ask that our colleagues in rural and regional areas look very carefully to see when the vaccine bus is coming to town, and try and do everything you can to mobilise people to get those vaccines into people's arms. And I know it's not just your responsibility, it's us as a community working together, but New South Wales Health can't do it by ourselves. We need your help.
Yeah, no, look, I think the message from community sector organisations is that, yeah, we do know these communities. We've been in these communities for a long time. We have long-standing relationships. So the more that we can help with the public messaging, with ensuring that the right people are coming forward to get vaccinated, the better. Sometimes it does feel, often in crises, that it is a top-down approach. So any opportunity to work more collaboratively and to involve community organisations early on would be, I think, a really positive thing. You mentioned before Blacktown and the initiative at Blacktown Hospital, which is fantastic. And we know in some other LGAs, community facilities have been repurposed and turned into vaccination hubs. But I think in Blacktown, there doesn't seem to have been as much of that. So certainly there is the hospital, but there are some other great community facilities that are really well located, where there's lots of parking, and that could be turned into a vaccination hub that's, in familiar surrounds and easily accessible. What's the process for getting those kinds of things up and running? It seems like some LGAs have a lot of them and others don't have as many. So is there a process that sits behind that helps work out where they should be located?
So there's three things that come together to help us have a hub. The first one is a community in need. So where we know that there's already a high level of vaccination or a high level of access through GP or pharmacy, we're less likely to put a clinic there. The second thing is, as you say, great locations. So we've started partnering with the police citizens youth clubs, for example, who often have quite good facilities with quite good parking and so on. We've partnered with religious organisations. And so it really is about nominating to your local health district vaccination coordinator, and they can help look to either have a specialised clinic as a one-off, or to open a clinic for several days or several weeks in some centres. So, and of course, it's where is their need? Who needs a small tailored clinic, or else we will not be able to vaccinate that particular group. So we're very, very keen to make sure that no one gets left behind. We've left enough people behind already with our vaccination strategy. We need to, bring everyone together, because otherwise we will have a world where the most vulnerable and the most hard to reach have been left behind, and that is nothing that anyone who works in public health wants. We're all about equity, and equity doesn't just mean everyone could get a dose. It's about making sure everyone has access to that dose with all the infrastructure that goes with it.
So I was hearing on the radio this morning that young people with pre-existing health conditions, notwithstanding that they're part of the Priority 1B rollout, they're still finding it difficult to receive vaccinations. What's being done to ensure that they can actually get vaccinated?
So I think the two key things that are happening is we're getting that increased supply of the mRNA vaccines that I know that particularly some of our young 16 to 18-year-olds, they can really only take the mRNA vaccines. And now we also have the medically vulnerable 12 to 15-year-olds who are also now able to take that Pfizer vaccine. For people who are interested, though, the AstraZeneca vaccine is available and is appropriate for anyone aged 18 and over. And I think many GPs actually have a supply, and so it really is about booking in with a GP who can administer those vaccines. Or the other thing that we've often seen work well is a family advocate, the person who's actually worked out the system, and trying to get a person who's either in your community group or in your family group to be the person, hey, I need an appointment, how do I do it? So in my family group, that's my sister, she's got the time, she's got the skills. And so when we have a family member or family friend who says, hey, how did you get that appointment? She knows which sites show what, and she's been able to do it. So I think that's been something that's worked quite well when you've got somebody who's computer literate in a family. But as I say, as those walk-up clinics get publicised, as those walk-up clinics come out, if you see something on your local health district website saying there's a clinic here, share it on Facebook, share it on Instagram, share it on TikTok, wherever you see it, wherever the people that you reach go to. If it's a paper newsletter, please print it out. Whatever it is, please reach that group and help share that information. We've got it up on our any social media way we can find. It's often in the community press as well. So if there's a local community language newspaper, it's often on local radio. I understand that if you are listening to sponsored community broadcasting in language at the moment, it's very hard to hear an ad for a car because it's all about COVID. We've bought all the airtime. So basically, however we can get people into those clinics and to help them feel confident that we will be looking after them, that we are not just, you know, telling people to get vaccinated for the hell of it. Because I think to some extent, many of us here in Australia have been spared the tragedy that is COVID, or of, you know, many of us have not. We've had relatives die overseas or significantly impacted, but at this point, it's not been the person that we see every day. But these days, it could be anyone that we know. It could be anywhere we go. And I think the less we see of that, because we have the vaccines available, the better we'll be at the end of the year.
So I have a question from one of our participants, which is that the Sikh community in Glenwood has been prepared and running a vaccination clinic. The community's responded very well to it, but the allocated vaccines aren't available. Isn't this a lost opportunity if you've kind of got everyone there ready to roll or keen for it to happen?
And I think, yeah, and I think this has been the real challenge, that the demand for the vaccine has outstripped supply at times. So trying to make sure that all the very good-hearted, willing people to vaccinate actually have vaccines available to them in a timely fashion, have those vaccines replenished in a timely fashion, is an ongoing challenge. And so we're working with the Commonwealth to do what we can to try and make sure that community groups who are as motivated and as organised and who are reaching a population do have that access to vaccine, but we will not get it right every time. We're trying.
It's improving. Things are now that
I would certainly hope that we are improving. Yeah. We've got much more vaccine than we had, you know, a month ago, 6 weeks ago, 8 weeks ago. We're in a much better place. Thank you, Poland. And that rest of the vaccine supply, I think we'll start seeing it being much more secure. One of the great challenges is no one wants to allocate a vaccine to a clinic in 3 weeks' time if you don't actually know you're going to have enough vaccine there to run a clinic, because people will have rearranged their lives, people will have done everything, and then to say to people, sorry, nothing for you, it's just a terrible thing to do to people. So sometimes you'll find that the opportunities drop from the sky at very short notice, and it's really about being ready to grab those opportunities when they fall from the sky, because it can be that chaotic, to be perfectly honest, but it's better to have a chaos of having too much and trying to work hard to distribute it than having too many eager people who've reorganized their lives that we cannot help.
Absolutely. So this next question relates to an ethical framework for triaging who will receive care in hospitals should COVID be occurring to such an extent that we actually have to ration or limit care. And I understand that New South Wales Health was preparing an ethical framework to guide decision-making in that situation. So given that we have had a recent surge in cases and we could now face such a scenario, We know that there are certain groups, you know, those particularly vulnerable groups that we've mentioned, who all want to see an ethical framework that doesn't automatically screen them out of receiving life-saving care. So has that ethical framework been completed, and were the representatives from those vulnerable groups involved in its development?
So New South Wales Health actually led the world just over a decade ago and developed those ethical frameworks, particularly for access to, say, ventilators and ICU beds. That information is continually revised and reviewed, and yes, it has had significant stakeholder consultation. The thing that we have done though now is we have bought the time to actually significantly and rapidly expand our capacity to treat people during a pandemic. It's about making sure though that people who don't have COVID also keep getting treated for all the other things that go wrong with us day to day, and making sure that no group is significantly disadvantaged as we bring our services back online, so that things like hip replacements and so on that actually improve quality of life significantly are still available to people who then do not have to wait 2 years in pain, for example, for access to treatment. I can't promise that won't happen, but I know that we've been, you know, using private hospital capacity to get through elective surgery post our reopening last year, and I think we'll probably see a very similar mobilisation once we get to a good place this year. But at the moment, everything is focused on how do we keep most people alive with an excellent quality of life. That's the key focus. And how do we look after people so that they are cared for and are wrapped around them during a difficult and challenging time. It's very hard to be sick at the moment. It is hard because you don't have your family with you. It is hard because as a family, you can't always visit the person or provide the care to the person in hospital you would normally care for. It's hard because you go to a doctor and they say you should have this surgery, but I can't do it at the moment. You'll have to come back to me in 3 months' time. It's a very hard time to be sick or to need hospital care at the moment, and it's very unsettling for many people. But I think the key thing is to make sure that we stay in touch with our GPs, and our GPs are able to escalate on our behalf when we need that sort of significant help. And also, if somebody's hospitalised, there are patient advocates available to you, so that if you feel that somebody that you would normally be providing care to, you're extremely worried and you're not getting enough feedback about their situation, the patient advocates in all New South Wales health facilities are there to help you with that.
So there, just to confirm, the ethical framework exists? There is an ethical
look,
framework.
I certainly understand that there's a national framework for allocation of ICU resources, and I believe that it has been consulted by greatly. The only thing I'm concerned about is, having said that, whether it got final sign off or whether everyone said, yay, we expanded ICU capacity, so we don't need this after all. So, but certainly there's the Australian New Zealand Intensive Care Society has certainly put a lot of work into thinking about that. But also, again, it comes back to things like cancer services. If you can only treat X number of people, who are the X number of people that you treat? And it's really about who can we do the most for?
Okay, so we might follow up to see if that.
Yep. I'll see if I can find it for you. Absolutely.
That would be great. So this now moves us into looking at some of those workforce vaccination requirements. And we understand that there are, or there soon will be, public health orders made mandating vaccination for all healthcare workers in New South Wales, and that first doses will need to be received by the 30th of September. And that this will apply to doctors, nurses, allied health and other clinical staff, as well as cleaners, administrative staff and other workers in healthcare organisations. So the question is that also going to apply to workers in health NGOs? How will it be monitored and enforced? And what if a worker is unable to secure a vaccination within that time frame despite their best efforts?
So I think the first thing to say is within New South Wales Health, it is not uncommon for a healthcare worker to have a requirement to be immunised against certain infectious diseases. So that includes hepatitis B, for example. And so part of your conditions for employment that you are actually vaccinated against some diseases. And that's mostly to protect our patients from us. COVID-19 will be no different. And the fact is that New South Wales Health employees, for example, have had access to vaccines since, well, let's put it this way, have had variable access to vaccine since much earlier this year. But across the state now, I think you would say that New South Wales Health employees definitely have access to vaccine. I think for other healthcare workers, again, there's a significant amount of AstraZeneca vaccine sitting there in doctors' offices ready to go into arms. So whilst it may not be an individual's preferred vaccine, it provides excellent protection. As I've said, very similar protection to the Pfizer vaccine, which people have been concerned about. And people who previously had a conversation with their GP when there was no COVID about, and their GP might have said to them, you should probably wait for Pfizer, should probably go and have that conversation again. Because I know that many people are worried about clots from the AstraZeneca vaccine, but COVID-19 causes clots. COVID-19 causes myocarditis. COVID-19 causes all the complications that you're worried about from the vaccine, but it actually is worse and it causes worse outcomes. And at the moment, what we're seeing are disability workers going to work, doing their vital care, and during that time that they're at work, coming home with COVID-19. Then give it to their housemates who are often also carers, and they then go to the next facility and take COVID with them there. It's been a litany, I think, of terrible stories of both the carers and the people they care for becoming affected by COVID. I know I've sat in our NDIS teleconferences every fortnight for many months now, trying to encourage people, but it's hard. It has been difficult to access. But I think as their supply comes online, again, it's about grabbing those appointments when they come up, or talking to your GP about the risks and benefits of the vaccine they've got sitting in the fridge. Because there are many, many GPs with that in the fridge all across New South Wales. And we really do need to get people protected for themselves, but also to protect the people they care for.
And so is it your understanding that that 30th of September deadline for first vaccination will apply to health workers in the NGO sector as well as all of those others across the health system?
I'll have to come back to you on that. But what I would say is if you're a healthcare worker, no matter where you are at the moment, don't delay, don't look at it as a date, just try and get in wherever you can as quickly as you can, because the sooner you start getting vaccinated, the sooner you'll finish being vaccinated. And that will, should provide you with a sense of relief as well as the people you care for. So one of the conversations my oncology nurse husband has with his patients, he sort of has said to them, do you expect me to be vaccinated? And they say, of course, I'm a cancer patient. My nurse should be vaccinated. And I said, well, that's why I want you to be vaccinated too. You can give it to me too. So let's do it both. And so it's that sort of two-way street. We've all got a bit of mutual obligation here as a community together where we look after each other. But again, making sure that the most vulnerable, the most disadvantaged do have that ability to access vaccine readily. And I think that's what's been the big barrier, but we're doing what we can to knock down those barriers. But
and what about people that can't be vaccinated for medical reasons?
Yeah, absolutely. And where that's the case, then their GP will be able to give them a certificate saying cannot be vaccinated. And if it's a key issue, then they'd be given, just as we do with the flu vaccine each year, different duties. Protect them, protect the community. So I think that's something that if you cannot be vaccinated, there would be some people who are allergic to, say, one of the additives in both vaccines who couldn't be vaccinated. And that would be something that if they had a certificate saying exactly why it wasn't suitable, they'd be able they may be exempt. Absolutely. We understand that happens.
And then protections would need to be built into the workplace to make sure.
Correct.
Yeah, other staff and vulnerable clients weren't.
Absolutely. So we just need to, so that would be the thing. It's about, can you continue to do face-to-face care when there's a massive outbreak going on, or do you need to be doing something different to protect yourself and to protect others?
So given we've already talked about the new requirements that were announced on the weekend, which means that childcare workers and disability support workers who live or work in an LGA of concern, as well as workers who are authorised and who have to leave an LGA of concern to go to work, they're supposed to have a first dose of the vaccine by the 30th of August. Or be tested through rapid antigen testing, although, as I've said, DCJ are recognising that is going to prove difficult. It just seems odd that there's a requirement for this group of workers to be vaccinated by the 30th of August, but then for healthcare workers, they've got until the end of September. Why is there that anomaly?
Look, I think at the moment, a lot of the disability programs have been suspended across the state. A lot of childcare has not been able to be given because we have seen significant numbers of disability, particularly the day programs. We've seen particular numbers of childhood centres where COVID has spread. And I think the key thing is that we need to protect the workers, but we also need to protect the people they're caring for. And so we haven't seen that same extent of transmission amongst healthcare workers and in healthcare facilities, which is not to say it can't happen. But if you had to look to see where we are seeing the significant transmission with vulnerable groups, it is in those disability settings and in those childcare settings particularly. It's been a really hard process because not only is it around the fact that many people will get sick, but for many people with disability, even the experience of having to be in self-isolation is challenging for them. Even the experience of trying to care for people whilst you've got your P2 mask and your visor. I had trouble just sitting for a couple of hours quietly in a P2 mask and a visor. I can't imagine how you could safely and easily do that with someone with dementia, say, in their home. So I think, yes.
Yeah, I mean, I think the issue is that 30th of August.
Time. It's very soon.
And that it can still be problematic in particular locations booking vaccination appointments. So, we certainly thought it was reasonable to write to the Minister and suggest that.
And I can see why people who do not have access would have issues with that, but also I'd really strongly recommend that as far as possible, please don't hope for an exemption. And even if there is an exemption, if you can do it, please do it. Don't wait, don't hesitate, please do it, because the issue is here, the issue is now. And I understand it's not easy for everybody, but please, if you can, do everything you can to meet that deadline, simply because, we've just seen such devastation. And if I never ever have to sit on a teleconference where we're talking about the alternatives of intubating and ventilating someone for sedation to keep them isolated safely versus calling police versus having their usual care workers able to take them out and do normal things with them, it will not be a day too soon for me.
So the discussions that NCOS and other peaks have had with DCJ have clarified that for the organisations that DCJ funds, setting up rapid antigen testing facilities and undertaking that will prove really problematic, given that often they're small organisations, but even for the bigger organisations, the fact that it's quite a specialised procedure, that there's a cost involved, that you need to have a health practitioner supervising it. There's a whole range of reasons as to why it's really not going to be possible for these organisations to set up their own facilities, and it's possibly not the most efficient way of getting it done either. Surely those considerations for DCJ funded NGOs are going to be similar for health funded NGOs?
And I think that we just need to take it as a total package of things. And again, if there are issues, then to bring it forward. I thought the I could be very wrong, but I thought the rapid antigen testing was an alternative to having regular PCR surveillance, not mandated as a thing that every organisation had to do. I could be incorrect about that. I will say though, you know, sitting where I am in regional New South Wales at the moment, where for some people it can take 5 to 7 days to get a test result back, that ability we've supplied some of the aged care facilities locally here in Western New South Wales with the rapid antigen tests for their workers before they go into work. And I think it's averted one tragedy already, simply because the prevalence of COVID is so high where we are at the moment. So it's fairly simple to do once you understand it. If you've got a registered nurse, particularly in an aged care facility or in a larger health organisation, that's within those boundaries of having a health professional look after it for you. And it's certainly in regional areas been meant that we've been able to get some services back up and running sooner. But again, we've worked in with the Commonwealth, who would be providing those tests to some of those services. So it could also be about the Commonwealth may also come through with some of those tests for some of those services too, depending on what the funding agency is. But it's a very different situation in parts of New South Wales. I was lucky. I had to have my test done because I was flying out to a regional area to help. I drove through the lab at midday and had my result back by 7 o'clock. The test I'd had taken in Dubbo, which I'd had reported back to me as negative, I got the result for that 8 days later. So it's a huge difference in regional areas versus being in Sydney. So I think, you know, that's where the rapid antigen tests may in the future actually help to try, where we've got an outbreak situation, to try and help staff get to work, or to have staff indicate that they probably shouldn't be there, and keep everyone, including their fellow workers, safe, as well as the clients they care for.
Yeah, but I think in for particular organisations and
challenging, hugely challenging,
and the time frame of the 30th of August.
Yes, very challenging.
Impossible.
So I'm sure you're making excellent representations to the Minister about that.
And we're certainly getting some further clarification on what it exactly means. But yes, certainly COVID testing is probably a more straightforward and easier to achieve requirement.
But again, depending where you're on New South Wales, because in some places it really is.
Timing issues associated with that as well. Absolutely. We've also had a raft of questions to do with accessibility for people with disabilities. And if a person has physical disability issues, which means that it's difficult or problematic for them to access a vaccination centre, query whether they can actually be vaccinated at home, or whether there might be patient transport available to make that possible.
So my understanding was the NDIA was making some funding available for the transport of people to their vaccination appointments, but also our New South Wales health clinics, many of them have been specifically designed to make sure that they're accessible. You can book accessible parking, for example, at the Olympic Park Vaccination Hub, and it's completely fine for people, you know, who are in wheelchairs and everything else. Some of the other hubs, the GPs with Pfizer and AstraZeneca, of course, are able to do it in their rooms, and some of them are also able to provide that sort of home service. So if you've got a GP that normally visits your client, they may well be able to offer that vaccination service, or if they are not able to, they may be able to negotiate with a neighbouring practice who can do that to get your clients vaccinated.
I don't know whether you know the answer to this, but if it were possible with the online booking to indicate if there were going to be accessibility issues or particular requirements, that would certainly make it easier.
Yeah, I think with some of the clinics there is that facility to do that, but perhaps not with all. But we're trying really hard to make, you know, in the ideal world, you wouldn't have to book, and you will know that when you go to a centre, no matter what your problems are, whether they're parking, whether it's wayfinding, whether it's understanding consent forms, whether it's, you know, whatever the barriers are, that we get rid of them. We're trying really, really hard. We've gone from a place where we were vaccinating our healthcare workforce to vaccinating several 100,000 people in a week. So I think it's been a huge challenge that my colleagues in the vaccine planning and in the local health districts have done amazingly to get to the point where we're not just vaccinating New South Wales health workers, but so many in the community. And yeah,
absolutely. An issue that has been raised with us, and I'm not sure if you're aware of it, is that there are different platforms for booking vaccinations, that it's actually not an integrated system, and the fact that federal, state and then private providers all have different online platforms is causing problems for people that have, you know, unlimited data and access to all the right technology and are reasonably digital, you know, literate when it comes to accessing things online. Are you aware of that as a problem, and is there a way that that can, by the look of it, you're more than aware, you may have had your own personal experience?
I wish I wasn't nearly as aware. You know, the fact that we only got the eligibility checker translated into some other languages in recent weeks, not months, weeks, is a source of significant frustration to many of us. And the plethora of vaccination booking systems, I think, is trying to help. The providers are just trying to do their best to make vaccines as accessible as possible. When everything went through the Commonwealth's booking system as a bottleneck, people couldn't find vaccine that was close to their workplace but wasn't close to their home address. We've tried to have other ways into the system rather than going through the eligibility checker each time. I think we are variably successful. To be honest, we're trying to make telephone bookings more accessible for people. We're trying to make sure that we've got the correct support materials in as many languages as we can, as well as in easy read resources, as well as in videos, because not everyone wants to read. A lot of people are either auditory learners or visual learners, and the printed word is not the best way to communicate. So we're trying lots of different ways to make it easier. But I think when you have a combination of private providers, state providers, federal providers, to think that we'll have a uniform system that works for everyone. I'm just glad that we can get our certificates out of the Commonwealth in one go, rather than trying to work out how we can fix the booking systems, because I think a lot of smarter people than me are working on it, and we're not there yet.
Yeah, and I guess for people with low or no digital literacy, people that don't speak English, it is a barrier, and it is going to be contributing to those low vaccination rates.
Absolutely. And I think that's where those walk-up clinics that we're trying to put into communities and trying to publicise through word of mouth are so important for those particular groups of people. If we do anything else, it just won't work.
Yeah, there is a question about accessible parking, and yes. I'm not 100% sure what the question is, but it might relate to there not being enough dedicated parking for people with disabilities, and whether there's a way that we can address that issue.
Yeah, so we do have quite a large accessible car park at Olympic Park, but I think with the numbers that we're seeing through now, it's probably not large enough. And so we'll continue to work with wherever we set up a clinic. It's one of the things that we do survey is the accessibility of that clinic, and we do our best to make sure that it is accessible, not just having a wheelchair ramp, but is accessible because it's got, you know, appropriate languages, is culturally appropriate, is accessible as far as is close to public transport, all of those things. But we're not going to get it right every time, and we're doing our best. But yes, accessibility is certainly, and including accessible parking, is one of the key things that we think about when we're setting up these vaccination hubs.
I have a question here which relates to people who don't have decision-making capacity. and who are not able to provide informed consent to access vaccination, how does that consent get given, or how is it gained? And does a legal guardian or supported decision maker provide that?
So it's exactly the same as for any other immunisation or any other medication. It's not a different or special process. It's exactly the same. So if you would normally have that person's enduring guardian give consent for a minor medical procedure, which is what a vaccination is, then that's what you do with this particular situation. The consent can be verbal. So say the person was in a supported independent living setting. If you normally ring up their guardian to say, I'd like to administer, an antibiotic, then you do exactly the same process to have that guardian give consent for that immunisation. So whatever you would normally do for the flu shot, you do for COVID.
Now, I've had confirmed in relation to accessible parking, there are two issues. One is that there isn't enough parking available, but the other is that if you book and indicate that you need accessible parking, it pushes back your appointment and it delays it by some weeks. So
that's probably because there's not enough parking. So, okay, I can take that back to my colleagues. I cannot promise to solve it, but I can try and help people know that it was an issue.
That would be fantastic. Thank you for that. We've got a few questions relating to people with caring responsibilities and the people that they're caring for. Where can a care recipient or carer go to access information in relation to the vaccine, about informed consent and decision making, but also about accessing emotional or behavioural support?
So for the vaccination or more generally for COVID?
In relation to the vaccination, if that's giving rise to some anxiety.
Yeah, so for the informed consent, so if you're coming to one of the New South Wales health clinics, that should be brought up with you as you go through it. I'm going to get it wrong because my brain, I think it's the Office of the Public Guardian here in New South Wales has actually put out some information for people to look at. And again, it's really important that we're not, not performing exceptionalism for the COVID vaccination. It's a registered medicine that's being administered by a registered health professional. It's not very different from the flu shot each year. So whatever you would normally do for the flu shot, you do for this. And you may find that you should have been doing more for the flu shot or you've already got an excellent process in place and that's all you need to do for this.
Fantastic. There's a question about whether carers are permitted to attend the vaccination venue and appointment with the person they're caring for. I'm assuming the answer to that is yes.
Generally, yes.
Yep.
But again, please make sure that there's something there that helps the person, because at the moment we're trying to limit the number of people in our vaccination hubs. You can imagine that if I've got one person to be vaccinated and they've got their son and daughter-in-law coming to take them there, they may only have one carer allowed into the centre with them, simply because we need to limit the number of people that are going into those hubs. I know that our hubs try to be very, very flexible. Theoretically, you don't bring your kids with them, but when I was in line at Westmead, there were people with their little kids with them and they just coped. They did not turn people away and say, come back without your kids. They just vaccinated them. So I think it's really important, though, that people understand that where we are limiting the number of helpers, it's not because we don't believe that people don't need help. It seriously is so that every extra person is an extra risk of introduction of COVID. You will have seen in the media, we have had a number of scares with COVID coming to our vaccination centres. So the fewer people we have in the line, the fewer people we have around the centres, the less chance we have of our centres becoming transmission hubs.
So carers are reporting that although they're eligible for the Pfizer vaccination under phase 1B, many are being advised when they turn up for their vaccination appointment that their documents proving eligibility, which might be a letter from a health professional or some declaration form that the Australian government has provided, they're being told that those that documentation is insufficient. Are you aware of what further proof would be required for carers to get vaccinated under phase 1B?
So I think there's a significant misunderstanding of what phase 1B is. Phase 1B was to make sure that people who had significant disabilities, significant medical conditions, healthcare workers and so on, were able to be vaccinated with the first appropriate available vaccine. So that could be AstraZeneca or it could be Pfizer. It's not to say you get Pfizer. It is only to say that you get vaccinated with the first appropriate vaccine. For a while there, when we had no COVID in our community, the best and most appropriate vaccine for people under 60 was the Pfizer vaccine. Now we have an epidemic in New South Wales. The first and most appropriate vaccine is either AstraZeneca or Pfizer. So unless you have a specific contraindication to the AstraZeneca vaccine, you may be referred away and told, no, just get the first available vaccine. It does not mean that you get Pfizer. It means you get the first available appropriate vaccine.
And then that issue of proof of eligibility under 1B, whether it's Pfizer or AstraZeneca.
Yeah, so 1B means you get the vaccine. It does not mean you get Pfizer. And I think that's been a misunderstanding with the idea that Pfizer was better than AstraZeneca. And I think it's often there are people who are, say, 65 turning up to say, well, I'm 1B, I should get Pfizer. And the answer is no, you are completely eligible for both vaccines. So there's someone over here who is 16 who is disabled, and the only vaccine I can give them is Pfizer. That's the one who gets the Pfizer, not the 65-year-old.
We've also heard from organisations supporting people with specific health conditions who feel that they're somewhat isolated from how decisions in relation to COVID-19 are being made. They've also highlighted that people are getting conflicting advice from their doctors, and some consumer organisations are having a hard time determining what advice they should be giving to their members, especially around vaccine risks. So, yeah, the question is, what is the latest advice on vaccines and risks for people with comorbidities? And what's being done to improve communication and provide clarity with people with morbidities, but also with those organisations supporting them?
I think we've had an epic shift in our communications in New South Wales about the vaccines. Because the information, because the evidence coming out is really showing that against Delta, both vaccines available in Australia are equally appropriate and equally safe and equally effective. Our key message is get vaccinated. Don't stand on which one, get vaccinated. And there are advantages and disadvantages to either. They have, very rare side effects, both of them. So please just get vaccinated is the key change in message from where we were trying to risk stratify people and say, well, as you get older, the risk of the side effects goes down and the risk of COVID goes up. So get the AstraZeneca, but everything else, we've had to change all of that. So there is a clear message to the New South Wales community, which is if you are over 18, the best vaccine for the vast majority of us is the first vaccine you can get in your arm. And that's the clear message. For younger people for whom there is only one vaccine licensed, and that is the Pfizer vaccine, that's for people aged 12 to 18. That is the only vaccine that is licensed for use in that particular age population. And that is why we recommend for that age group that they get the Pfizer vaccine.
And then for adults who have those comorbidities?
They are both fantastic vaccines, and you should get the first available vaccine available to you, particularly if you've got comorbidities. It doesn't matter if that's immunosuppression, it doesn't matter if it's cancer, it doesn't matter if you've had a transplant, it doesn't matter even if you've had a DVT in the past. The number of people who cannot take the AstraZeneca is minuscule, but the number of people who, if they've had a clotting tendency in their family, who get COVID, who will have a clot is large. So the first vaccine for the vast majority of us here in New South Wales is the first vaccine we can get in our arm.
Dr. Jan, you have done a sterling job, and I feel like you've really been under the pump, but clearly you're used to operating in that kind of environment. I wondered if I could finish, given you're in Dubbo, with a question relating to the Aboriginal community and the fact that such a fantastic job was done for the first outbreak in terms of keeping COVID out of Aboriginal communities, and we saw Aboriginal leaders and Aboriginal community controlled organisations really do this amazingly effective job at collaborating with health departments and with other stakeholders to protect their really vulnerable communities. Are you confident that we're doing enough this time around to support Aboriginal leaders and Aboriginal organisations, and that we are going to be able to get on top of it? Given the really vulnerable position that a lot of those communities are in. And as you highlighted at the beginning, you know, housing plays such an important role, and we know that inadequate housing and overcrowding is very much a feature of some of these communities, and it is putting them at heightened risk. So are we doing enough? What else can we be doing to keep these communities safe?
So I think the thing that gives me a lot of hope here is seeing a town's first dose of vaccination rate go from 10% to over 85% in a single week. So that gives me a huge amount of hope that we're getting the vaccine to the people who need it most. I know that the Commonwealth teams will be going door to door in some of the remote locations and offering both education and vaccination. I know that we've got many, many vulnerable communities around New South Wales that COVID still has not touched. And I think we do need to be getting on the front foot with educating our regional and rural communities with the lessons that we've learnt the hard way in Sydney, with the lessons that we've learnt the hard way here in Dubbo, that unfortunately Delta is a very different beast to what has come before. That when the first case or the first sewage ping, it's usually the sewage that goes first, tells you there is something happening, that's a signal to stay home. It's a signal to start limiting, you know, most of us are under stay-at-home directions, some of us are not under such tight directions as others, but making sure that we really stick to keeping to ourselves at home, working from home where we can, and when we do need to leave home, as so many people do to get healthcare and so on, making sure that we're protecting ourselves with a mask as far as we can, but also working with community is the only way we can do effective contact tracing for a lot of people who have no charge left on their phones, who've got nowhere else to be. Having appropriate alternative accommodation for people so that if one person is sick, making sure that they don't make the other 9 people in the household sick. And we're working very hard with all the partner agencies to try and make sure that we've got support in place, information in place, culturally appropriate and safe information in place, and not just information, but action. Not, you know, culturally safe and appropriate action in place, because I think that's the key. It's all very well to hand out a fact sheet. A fact sheet has very rarely changed anyone's life, in my opinion. But if you actually have people there who are from your community that we've empowered to spread positive messages in the community, that we've helped persuade that it's worthwhile being vaccinated to help protect the community, that's where I think that's the thing. But it's on us as New South Wales Health to make sure that the community has the information they need to be able to persuade each other. And I think that's, you know, doesn't matter what part of our community we're in, that's what we all need to do, is have that information to be a powerful advocate to protect each other, because staying at home won't do it by itself. Working from home won't do it by itself. Wearing a mask won't do it by itself. We are going to need this vaccination rate up. I'm not saying that for a hope for reopening, but I'm saying that because I'm seeing the devastation that this disease is, you know, wreaking across families. You know, there's some heartbreaking stories where, you know, we see one family member pass on, and then 2 days later we see a different family member from that same family pass on, and that's us feeling sad as epidemiologists. But I cannot imagine the grief that is in that family group and that community, and that's what we want to protect and prevent. So
I know I did say that was my last question, but just on the issue of hope, like we know that the pandemic and the lockdown is really taking a toll on people's mental health, and certainly in the sector, be it the community service or health part of the NGO sector, we know that staff are under the pump and really working under challenging conditions and dealing with really complex matters on a daily basis, and that the pandemic has really upped the ante when it comes to that, and that is making everyone incredibly exhausted, and you know, there's lots of frustration, and it's an incredibly difficult and exhausting time for everyone. What do you think Christmas is going to look like? Are we going to be in a position where a lot of these restrictions will have eased and we will be able to perhaps not get back to normal life or life as we knew it, but certainly be able to enjoy Christmas with family and friends and have some of these restrictions eased?
So I have incredible hope. I really do. I think the fact that 12 months ago, I could not guarantee to anyone who asked me that we would have a vaccine that would work, that we would have a vaccine that would be available in quantities to protect the population. And I'm a huge advocate in believing in vaccination. I've seen chickenpox go from a disease that I used to treat in kids in the emergency department and have adults ventilated in intensive care to becoming a disease that is now very rarely seen to that extent. I've seen a change in the prevalence of pneumococcal meningitis, of meningococcal septicemia. So we have lived with infectious diseases. Other countries live with, you know, significant infectious diseases all the time, like dengue and malaria. We've been very privileged here in Australia for a very long time. We will get to a place where we can live with this. We may still have tragedies. We may still have outbreaks that we need to bunker down while we get the new variant vaccine done. But it will only be so that we can keep each other safe. And I think we will learn to live with this. And I'm truly hoping that we'll keep developing better and better vaccines so that what we are learning to live with is just a minor inconvenience and a sore arm every year or every 2 years or every 5 years, and not what we've been going through now. But we're good. We're humans. You see the amount of kindness and, you know, the joy in the small things that people have brought to each other. And as much sometimes I walk around shaking my head going, you know, usually soon after that, there's something that makes me remember how good and how wonderful people are. But we can't rely on people's goodness and wonderfulness. We need to look after them as well. And so just checking in on each other, being kind to each other, understanding that most people, even if they come from a very different place than you, are doing it from a place of goodness when they're asking me, are you really sure about those vaccines, even though I've said it 100 times. It's not because they're trying to be obstructive. They actually are genuinely curious or genuinely worried, and trying to reassure people that these are the same sorts of conversations that we have when you have a urinary tract infection and you need antibiotics, or when you have a headache and we say Panadol is okay. It's the same sorts of conversations, and I think we just need to have trust in each other that we'll get through it.
Fantastic. Look, thank you so much, Dr. Jan, for joining us. We really appreciate your time today and all the fabulous work that you and your colleagues are doing to keep us all safe and to get us back to where we can open up and live life a bit more freely. We really appreciate your frankness and your provision of such a wealth of information. So it would be great to see you again under different circumstances. But we are here and ready and willing to help, given our work with very vulnerable population groups. So thank you again, and keep up that amazing job that you're doing. We really appreciate it.
Thank you.
Absolutely. I just want to echo that as well. Thank you so much, Dr. Fizzell, for coming to answer those hard questions for us. We really appreciate it. And also to Joanna Quilty for asking the questions. I hear ABC's looking for a new presenter of Q&A. You might be up for the task. But before we finish up, I know Joanna is going to give us a bit of an update on the Social Sector Transformation Fund.
Hi Rob, it's Elise here. I think Joanna has had some connection issues on her end because we've all frozen. Perhaps you could kick off the update for us.
Brilliant, happy to do that. So, just quickly, you are probably aware of the Social Sector Transformation Fund, which was 50 million available to NGOs across the state to support NGOs through change. So tranches 1 and 2 of the fund were distributed by DCJ by June. And since then, the New South Wales government has announced the $55 million that was left in the fund that will be allocated to those tranche 1 organisations. And so those organisations are those that already have funding arrangements with DCJ and New South Wales Health. And finally, that the New South Wales government has also announced a third tranche of the fund for sector grants to deliver advisory and information services, which begin this month. And there have been 7 organisations who've received one-off grants to provide advice, resources and support to health and social service sectors. And advice and support can be short and general, or it can be more detailed and in-depth. And those 7 organisations are Info Exchange, who will provide digital and information technology advisory services, migrate organisations to the cloud and develop digital capability. The Social Impact Hub to deliver governance and strategy support, including facilitating outcome measurement. NGOs to support resilience building for emergency responses, and to convene a symposium to share the results, opportunities and challenges that the Social Sector Transformation Fund has generated. ABSEC to provide a holistic model of support, providing practical advice and solutions to help organisations improve how they do business. Justice Connect to deliver a range of legal services to help board members, staff and organisations access legal advice and information, plus conduct legal health checks to 100 organisations. And the Association for Child Welfare Agencies, ACWA, to deliver on-demand leadership training and workforce development activities through online workshops, face-to-face trainings on topics such as mentoring and telepractice. And finally, CIFA, Social Enterprise Financial Australia, to deliver a range of strategic analysis, governance support, quality assurance and evaluation services to help organisations future-proof their operations. And people who are interested can register their interest at ssTF@ncos.org.au. Okay, so we're just wrapping up now. So on the screen there, you'll see an email address, mo-ngo grant program at health.nsw.gov.au, and that is the email address for the NGO COP. And I just want to appreciate everyone putting in their questions. We didn't get to everything, but we will provide those questions to the Ministry of Health. I know there's a few questions around health vaccinations for healthcare workers, how that applies to NGOs, that we'll make sure we get those out to health-funded NGOs around that advice. And I know I've been getting lots of questions around rapid antigen testing as well, and we'll make sure that we aim to get that information out to you. And before I hand back to Elise to close us off, we will make this webinar available to everyone. However, it may get taken down after a month, depending on the currency of that information. And I think most importantly is to say that you're not alone in this. So we do encourage you to contact your local public health units if there's an incident of COVID-19 at your service with your staff or people who access your service. Contact your contract manager if there's any changes to the service provision, to discuss any negotiation around reporting or service adaptations. Contact your relevant peak if you have any questions, and if we don't have the answer, we'll find out for you. So I will now hand over to Alice to wrap us up.
Thanks, Rob. And I think you did a really good job of actually wrapping up a lot of the session, but just thank you, to Joanna and Jan, for what's been a really informative session. I think Jan did an incredible job of answering some of those questions, and we'll pick up on some of the other ones that came through the chat and see if there's any others we need to answer. It was really good to finish on that positive note as well of what we have to look forward. So thanks everyone for your time today and for all your amazing work this and last year to support all communities that we work with, and we'll close the session. Thank you all for coming.
Thank you.